Hi, this is Dr. J. Park with Cosmetic Medical Training. This is your beginner botulinum toxin injection training course. This is a shortened version of our online beginner botulinum toxin training course. In the complete online course, it goes over everything, including the history of botulinum toxin, the different botulinum toxins and their contraindications, warnings, side effects, drug interactions, and clinical pharmacology. You will learn how to inject the glabellar area, brow lift, horizontal frontalis, crow's feet. We will also talk about treatment failures, complication specific pearls, pricing, and marketing of your botulinum toxin. Let's begin. There are a variety of botulinum toxins available commercially, FDA approved in the US market. Let's go over a few of the top botulinum toxin products that are currently available. Botox Cosmetic, also known as onabotulinum toxin A, is a drug used in adults for the temporary improvement in the appearance of moderate to severe glabellar lines associated with corrugator and or procerus muscle activity. It is also indicated for the treatment of moderate to severe lateral canthal lines associated with orbicularis oculi activity and moderate to severe forehead lines associated with the frontalis muscle activity. This drug is supplied in a single 50 units or 100 unit vial. It should be reconstituted with sterile, preservative-free 0.9% sodium chloride to obtain a solution concentration of 4 units per 0.1 ml. The reconstituted Botox Cosmetics should be clear, colorless, and free of particulate matter. It should be administered within 24 hours after reconstitution and stored in a refrigerator during this time period. The vials are for single dose only. The drug is administered intramuscularly into 5 sites, 2 each corrugator muscles and 1 in the procerus muscle for a total of 20 units. The dosage for simultaneous treatment of lateral canthal lines is 64 units, comprised of 20 units for the forehead, 20 units for the glabellar line, and 24 units for the lateral canthal lines. The drug should be administered no closer than 1 centimeter above the central eyebrow to reduce the risk of ptosis. The product is supplied in a vacuum-dry powder in a single-dose vial of 50 or 100 units. Unopened vials should be stored in a refrigerator. Reconstituted Botox Cosmetics should also be stored in a refrigerator and used within 24 hours. Dysport, also known as abobotulinum toxin A, is a drug that is indicated for the temporary improvement in the appearance of moderate to severe glabellar lines associated with procerus and corrugator muscle activity in adults less than 65 years of age. This drug is supplied as a dry powder in a single dose, 300 units and 500 unit vials. It should be reconstituted with preservative-free 0.9% sodium chloride injection. The reconstituted Dysport should be a clear, colorless solution, free of particulate matter. It should be used for only 1 injection session and for only 1 patient. Once reconstituted, it can be stored in a refrigerator, protected from light for up to 24 hours until time of use. The dose of treatment of glabellar lines in adults is a total of 50 units given intramuscularly in 5 equal aliquots of 10 units each to achieve a clinical effect. The drug should be administered no more frequently than every 3 months. To reduce the risk of ptosis, the drug should be injected at least 1 centimeter above the bony supraorbital ridge and no closer than 1 centimeter above the central eyebrow. This is supplied as a sterile powder in a single-dose glass vial. Unopened vials must be stored in a refrigerator and protected from light. Xeomin, also known as incobotulinum toxin A, is indicated for the treatment of adult patients for moderate to severe glabellar lines with corrugator and procerus muscle activity. It should be reconstituted with only 2.5 ml sterile preservative-free 0.9% sodium chloride to obtain a solution at a concentration of 4 units per 0.1 ml. The frequency of Xeomin should be no sooner than every 12 weeks. The drug is administered intramuscularly into 5 sites, 2 injections into the medial corrugator and lateral corrugator's muscles respectively, and 1 injection in the procerus muscle for a total of 20 units. To reduce the risk of ptosis, the drug should be injected no less than 1 centimeter above the superior orbital rim. Supplied in a single dose vial of 50, 100, or 200 units, unopened vials can be stored at room temperature or in a refrigerator or in a freezer. Reconstituted Xeomin should not be used if the solution appears cloudy or contains particulate matter, or any unused solution should be discarded after 24 hours. Juveau, also known as Prabotulinum toxin A, is indicated for the temporary improvement in the appearance of moderate to severe glabellar lines associated with corrugator and or procerus muscle activity in adult patients. This drug is supplied in a single dose, a 100-unit vial. It should be reconstituted with only 2.5 ml sterile preservative-free 0.9% sodium chloride to obtain a solution concentration of 4 units per 0.1 ml. The reconstituted Juveau should be a clear, colorless, and free of particulate matter. It should be administered within 24 hours after reconstitution and stored in a refrigerator during this time period. The vials are for single dose only. The drug is administered intramuscularly into 5 sites, 2 injections into the medial corrugator and lateral corrugator muscle respectively, and 1 injection to the procerus muscle for a total dose of 20 units. To reduce the risk of ptosis, the drug should be injected no less than 1 centimeter above the superior orbital rim. It is supplied in a vacuum-dry powder in a single-dose vial of 100 units. Unopened vials should be stored in a refrigerator and protected from light. Daxify, or Daxibotulinum toxin A, is indicated for the temporary improvement in the appearance of moderate to severe glabellar lines associated with corrugator and or procerus muscle activity in adult patients. This drug is supplied in a single dose 50-unit and 100-unit vials. It should be reconstituted with sterile preservative-free 0.9% sodium chloride to obtain a solution at a concentration of 8 units per 0.1 ml. The reconstituted Daxify solution should be clear to slightly opalescent and colorless and free of particulate matter. It should be administered within 72 hours after reconstitution and stored in a refrigerator during this time period. The drug is administered intramuscularly into 5 sites, 2 injections into the medial corrugators and lateral corrugators, and 1 injection into the procerus muscle for a total of 40 units. To reduce the risk of ptosis, the drug should be injected no less than 1 centimeter above the superior orbital rim. It is supplied as a sterile powder in a single-dose vial of 50 or 100 units. Unopened vials should be stored at room temperature or refrigerated and protected from light. Botulinum toxin drugs are contraindicated in patients with the following: known hypersensitivity to any botulinum toxin products or to any of the components in the formulation. This includes specific hypersensitivity to cow's milk protein, which may be present in trace amounts in some formulations. Another contraindication is the presence of infection at the proposed injection site. Here are some of the warnings and precautions related to botulinum toxin. Lack of interchangeability between botulinum toxin products. The potency units of botulinum toxin products, including Botox Cosmetic, Dysport, Xeomin, Juveau, and Daxify, are specific to the preparation and assay method utilized. They are not interchangeable with other preparations of botulinum toxin products. Therefore, units of biological activity of these products cannot be compared nor converted into units of any other botulinum toxin products assessed with any other specific assay method. Post-marketing safety data from botulinum toxin products suggests that botulinum toxin effects may, in some cases, be observed beyond the site of local injection. The symptoms are consistent with the mechanism of action of botulinum toxin and may include the following: asthenia, generalized muscle weakness, diplopia, blurred vision, ptosis, dysphagia, dysphonia, dysarthria, urinary incontinence, and difficulty breathing. These symptoms have been reported hours to weeks after injection. Swallowing and breathing difficulties can be life-threatening, and there have been reports of death related to the spread of toxin effects. Patients should be advised to seek immediate medical care if swallowing, speech, or respiratory difficulties occur. Although no serious adverse reactions of distant spread of toxin effects associated with these products have been reported in clinical studies for their specific approved indications, these reactions are possible. Serious adverse reactions with unapproved use. Serious adverse reactions, including excessive weakness, dysphagia, aspiration pneumonia, with some adverse reactions associated with fatal outcomes, have been reported in patients who receive botulinum toxin injections for unapproved uses. These adverse reactions are not necessarily related to the distant spread of toxin, but may have resulted from the administration of botulinum toxin products to the site of injection and/or adjacent structures. In several cases, patients had pre-existing dysphagia or other significant disabilities. There is insufficient information to identify factors associated with an increased risk for adverse reactions associated with the unapproved use of botulinum toxin products. The safety and efficacy of botulinum toxin for unapproved use have not been established. Hypersensitivity reactions. Serious immediate hypersensitivity reactions have been reported for botulinum toxin products. These reactions include anaphylaxis, serum sickness, urticaria, soft tissue edema, and dyspnea. If such reaction occurs, further injections of botulinum toxin products should be discontinued and appropriate medical therapy immediately instituted. The use of botulinum toxin products in patients with known hypersensitivities to any botulinum neurotoxin or to any components of the formulations could lead to a life-threatening allergic reaction. Cardiovascular system. There have been reports following administration of botulinum toxin of adverse events involving the cardiovascular system, including arrhythmia, myocardial infarction, and some fatal outcomes. Some of these patients had risk factors including pre-existing cardiovascular disease. Use caution when administering to patients with pre-existing cardiovascular disease. Increased risk with pre-existing neuromuscular disorders. Individuals with peripheral motor neuropathic diseases, amyotrophic lateral sclerosis, or neuromuscular junction disorders such as myasthenia gravis or Lambert-Eaton syndrome should be monitored particularly closely when given botulinum toxin. Patients with neuromuscular disorders may be at increased risk for clinical significant effects, including generalized muscle weakness, diplopia, ptosis, dysphonia, dysarthria, severe dysphagia, and respiratory compromise. Dysphagia and breathing difficulties. Treatment with botulinum toxin products can result in swallowing or breathing difficulties. Patients with pre-existing swallowing and breathing difficulties may be more susceptible to these complications. In most cases, this is a consequence of weakening of the muscles in the area injected that involve breathing or swallowing. Deaths as a complication of severe dysphagia have been reported after treatment with botulinum toxin. Dysphagia may persist for several months and require the use of feeding tube to maintain adequate nutrition and hydration. Aspiration may result from severe dysphagia and is a particular risk when treating patients in whom swallowing and respiratory function is already compromised. Treatment with botulinum toxin may weaken the neck muscle that serve as accessory muscles of ventilation. This may result in critical loss of breathing capacity in patients with respiratory disorder who may become dependent upon these accessory muscles. There have been post-marketing reports of serious breathing difficulties, including respiratory failure. Patients treated with botulinum toxin may require immediate medical attention should they develop problems with swallowing, speech, or respiratory disorders. These reactions can occur within hours to weeks after injection with botulinum toxin. pre-existing condition at the injection site. Caution should be used when botulinum toxin treatment is used in the presence of inflammation at the proposed injection site, ptosis, or excessive weakness or atrophy present in the target muscle. This also applies to patients who have marked facial asymmetry, deep dermal scarring, thick sebaceous skin, or when subjects do not respond to 20 units of botulinum toxin. Use caution when administering to patients with surgical alterations to the facial anatomy. Do not exceed the recommended dosage and frequency of administration. Corneal exposure and ulcerations. This may require protective drops, ointment, or the closure of an eye by patching or other means. Because of its anticholinergic effect, botulinum toxin should be used with caution in patients at risk of developing narrow-angle glaucoma. To prevent ectropion, botulinum toxin products should not be injected into the medial lower eyelid area. Ecchymosis easily occurs in the soft tissues of the eyelid. Immediate gentle pressure at the injection site can limit that risk. Here is the list of major side effects taken from the Xeomin botulinum toxin package insert. Most botulinum toxins share similar side effect adverse event profiles. Please check your package insert for a detailed list. This one lists headaches, facial paresis, and injection site hematoma as some of the more common side effects. Here is the list of major side effects taken from the Xeomin package insert. Most botulinum toxins share similar side effect adverse event profiles. Please check your package insert for the detailed list. From this, you can see that headaches, facial paresis, and injection site hematoma are some of the more common side effects. Other adverse reactions include eyelid disorder, such as eyelid edema, dry eye, and eye pain. This is another table of adverse reactions that include other reactions such as facial asymmetry, nausea, and skin burning sensation. Drug interactions. Aminoglycosides and other agents interfering with neuromuscular transmission. Co-administration of botulinum toxin and aminoglycosides or other agents interfering with neuromuscular transmission, such as curare-like compounds, should only be performed with caution as the effects of the toxin may be potentiated. If co-administered, the patient should be closely observed. Other interactions such as anticholinergic drugs. Use of anticholinergic drugs after the administration of botulinum toxin may potentiate systemic anticholinergic effects such as blurred vision. Other neurotoxin products. The effects of administering different botulinum neurotoxin products at the same time or within several months of each other is unknown. Excessive neuromuscular weakness may be exacerbated by the administration of another botulinum toxin prior to the resolution of the effects of the previously administered botulinum toxin. Muscle relaxants. Excessive weakness may also be exacerbated by administration of muscle relaxants before or after administration of botulinum toxin. Specific populations. Pregnancy. There are no adequate data from post-marketing surveillance on the development risk associated with the use of botulinum toxin in pregnant women. In animal studies, administration of botulinum toxin during pregnancy resulted in adverse effects on fetal growth at clinically relevant doses, which were associated with maternal toxicity. Lactation. There are no data on the presence of botulinum toxin in human or animal milk, the effects of breastfed child, or the effects of milk production. The developmental and health benefits of breastfeeding should be considered along with the mother's clinical needs for botulinum toxin and any potential adverse effects on the breastfed infant from botulinum toxin or from underlying maternal conditions. Pediatric use. Safety and effectiveness in patients below the age of 18 has not been established for botulinum toxin. Geriatric use. In clinical studies of botulinum toxin, the responder rate appeared to be higher for subjects younger than 65 than for subjects 65 years and older. However, no overall difference in safety and effectiveness were observed between older and younger patients. Other clinical studies have not identified differences in responses between older and younger patients. but increased sensitivity in older patients cannot be ruled out. Female and male reproductive potentials. In rats, botulinum toxin produced adverse effects on mating behavior and fertility. Ethnic groups. Exploratory analysis in trials for glabellar lines in African American subjects with Fitzpatrick skin type 4, 5, and 6, and in Hispanic subjects suggested that response rate at day 30 were comparable to and no worse than the overall population. The mechanism of action of botulinum toxin involves several steps. 1. Binding. The botulinum toxin binds to specific surface receptors on nerve endings. This binding is facilitated by the heavy chain of the toxin molecule. 2. Internalization. Once bound, the toxin is internalized through the nerve terminal through a process known as receptor-mediated endocytosis. 3. Inhibition of acetylcholine release. Inside the nerve terminal, the toxin cleaves a presynaptic protein called SNAP25. This protein is integral to the successful docking and release of acetylcholine, a neurotransmitter responsible for muscle contraction, from vesicles situated within the nerve endings. The cleavage of SNAP25 inhibits the release of acetylcholine, leading to a localized reduction in muscle activity. 4. Muscle response. The affected muscle undergoes partial chemical denervation, which leads to muscle atrophy. These changes contribute to the muscle's reduced activity and wrinkle smoothing. The effects of botulinum toxin are not permanent. Over time, the muscle begins to regain its strength through a process known as reinnervation. This occurs as the neuromuscular junction recovers from SNAP25 cleavage and new nerve endings are formed. The parent nerve terminal regains function, and the collateral terminals, which have sprouted during the period of denervation, retract. This gradual recovery of muscle function ensures the safety of botulinum toxin used in cosmetic medicine, as the effects can be reversed over time. No formal pharmacodynamic studies have been conducted with these toxins. The primary pharmacodynamic effect is due to chemical denervation of the treated muscle, resulting in a measurable decrease of compound muscle action potential, causing a localized reduction in muscle activity. The return of increased muscle tone following the injection typically occur within 3 to 4 months. Using currently available analytical technology, it is not possible to detect these toxins in the peripheral blood following intramuscular injection at the recommended doses. Long-term studies in animals have not been performed to evaluate carcinogenic potentials of these toxins. They were negative in a battery of in vitro and in vivo genetic toxicologic assay. In fertility studies, reduced fertility was observed in male and female at high doses. The patient consultation is a critical component of a successful botulinum toxin treatment. It provides an opportunity to understand the patient's concerns, set realistic expectations, and plan the treatment accordingly. Patient history. Begin with comprehensive history including medical conditions, previous cosmetic procedures, allergies, and medications. This information is crucial to assess the suitability of botulinum toxin treatment and to anticipate potential complications. Informed consent. Explain the procedure, potential risk, benefit, alternative to the patient. Ensure they understand the information and have the opportunity to ask questions. Obtain a written consent before proceeding with the treatment. Photographic documentation. Take standardized before photos from multiple angles. These photos serve as reference for treatment planning and to evaluate for treatment outcome. Patient examination. Number 1. Address the patient's concern. Provide a mirror. Ask the patient to point out the area of concern. Ask them to animate their face to illustrate the concern better. This step helps to understand the patient's perception of their appearance and set aesthetic goals. 2. Facial analysis. Conduct a thorough examination of the face, noting asymmetries, skin quality, muscle strength, and the depth and location of wrinkles. Point out any asymmetries to the patient and document them in the medical record. 3. Glabellar wrinkle scale. Use the Glabellar wrinkle scale to assess the severity of wrinkles. This scale categorizes wrinkles into 4 types, each associated with specific age group and recommended treatment. Type 1. Early wrinkles, 20 to 30s. Botulinum toxin is typically sufficient. Type 2. Wrinkles in motion, 30 to 40. Botulinum toxin and possibly dermal filler may be needed. Type 3. Wrinkles at rest, 50 and older. Botulinum toxin and dermal fillers will likely be required. Type 4. Only wrinkles, 60 to 70. Botulinum toxin and dermal filler may not be enough. Consider facelift or laser resurfacing. Glabellar spread test. This test helps determine if botulinum toxin alone will soften a patient's frown line. Spread the glabellar wrinkle apart with your thumb and index finger. Patients with thick skin and deep dermal folds who do not improve with manual spreading may need dermal filler injections alongside a botulinum toxin. Setting realistic expectations. Discuss the expected outcomes and limitations of botulinum toxin treatment. Emphasize that the typical goal is to enhance the natural beauty and not to completely change their appearance. Patient education. Educate the patient about the procedure, post-treatment care, and the need for follow-up sessions. Explain that the effects of the botulinum toxin are temporary and regular treatments are necessary to maintain the results. Treatment plan. Based on the patient's concern, facial analysis, and wrinkle assessment, develop a personalized treatment plan. Discuss the plan with the patient, including the areas to be treated, the type of botulinum toxin to be used, and the estimated cost. The patient consultation is not just about gathering information, but also about building a therapeutic relationship with the patient. A well-conducted consultation can lead to high patient satisfaction and a successful treatment outcome. Counseling. Patients should be informed that injections of botulinum toxin may lead to potential swallowing, speaking, and breathing difficulties or other unusual symptoms. If such symptoms develop, existing symptoms worsen. Patients should also be aware that these injections may cause dry eye. In addition, patients should be advised to avoid driving a car or engaging in other potentially hazardous activity if they experience loss of strength, muscle weakness, blurred vision, or drooping eyelids. It's important to note that these are general guidelines. Specific details may vary between toxins. Always refer to specific patient counseling information for each toxin for the most accurate information. The glabellar region, often referred to as frown lines, is a common area for botulinum toxin injection. The primary muscle involved in the region are procerus and corrugator muscles. Procerus is a muscle that originates from the nasal bone and inserts into the medial forehead and skin of the brow. Its action is to draw the medial brow inferiorly, contributing to the horizontal line seen on the forehead. The corrugator muscle originates from the medial superciliary arch and inserts into the skin of the medial forehead. It draws the brow medially and inferiorly, leading to the formation of the vertical lines between the eyebrows. Identifying the correct landmark is crucial for a successful injection. Here are the key landmarks for glabellar injections. Medial corrugator. The injection should be 1 centimeter above the bony rim and vertical to the medial canthus. Lateral corrugator. The injection should be 1 centimeter above the bony rim and just medial to the vertical midpupillary line. Procerus. The injection should be just above the crossing point of the X form by drawing a line from the medial eyebrow to the contralateral medial canthus. All injections for glabella are intramuscular and perpendicular to the skin. The needle should be above the periosteum. It's important to note that the frontalis muscle overlaps the corrugator superficially, so a superficial injection may cause paralysis of the inferior edges of the frontalis muscle. Therefore, corrugator injections should be deep intramuscular injections. Previously, the recommendation was to inject until hitting the periosteum, then pull back several millimeters before injecting the botulinum toxin. However, this technique has been modified and has been found to increase the incidence of headaches in patients and dull the needle for subsequent injections. The standard FDA-approved dose for Glabellar, as per the Botox Cosmetic package insert, is 20 units. However, men may require an additional 1 to 2 units per injection site due to typically a larger muscle mass. The package insert for Botox Cosmetics, Xeomin, and Juveau recommends a total of 20 units, which is 4 units injected over 5 locations equally. Daxify recommends 8 units per injection site, and Dysport recommends 10 units per injection site. The complication rate for glabellar injection is 1 to 3%. Potential complications include the following: litosis. This can occur if the injection is too close to the orbital rim, as diffusion of the botulinum toxin may affect the levator palpebrae superioris muscle. Brow ptosis. This can occur if the injection is too superficial or too lateral to the midpupillary line. Complications can occur as soon as 48 hours or as late as 7 days post-injection and may persist 4 to 8 weeks. Solutions include the following: litosis, apraclonidine, 0.5% drop can be used, 1 drop to the affected eye 3 times a day. This stimulates the mular muscles to minimize the ptosis. Oxymetazoline, 0.1%, which has been FDA approved for litosis, can also be used. Brow ptosis. The brow lift injection technique can be attempted. However, typically time is required for the frontalis movement to reappear to lift the brows up again. The primary indication for injecting the frontalis muscle is to reduce the appearance of horizontal forehead lines. These lines are a result of the repetitive contraction of the frontalis muscle, which lift the eyebrows and furrow the forehead. The frontalis muscle is a broad muscle that varies in size and shape among individuals. Some may have a narrow or a broad frontalis, while others may have a tall or short frontalis. The shape can also vary, being either a V shape or a rectangle shape. It is important to palpate the muscle before injecting to understand its size and shape. The frontalis muscle originates from the gallei aponeurosis and inserts into the muscles of the glabellar complex. The action of the frontalis muscle is to lift the eyebrows superiorly and depress the scalp inferiorly. The fibers of the frontalis muscles are oriented vertically, while the visible wrinkles formed by the contraction of the frontalis muscles are horizontal. The frontalis muscle is located on the forehead and is easily palpable. The lower 2 to 3 centimeters of the frontalis muscle is used to elevate the eyebrow, and injection here should be avoided. The medial portion of the frontalis muscle fiber may be more fibrous or absent and may need less injection. The key point about the frontalis is to avoid injecting near the lowest horizontal wrinkles, or at least 2 to 3 centimeters above the brow. The injection technique is subcutaneous and typically placed about 2 centimeters apart. Typically, 2 units of botulinum toxins are injected per site. Men may require an additional 1 to 2 units per injection site due to typically having a larger muscle mass. If you look at the package insert for Botox Cosmetics, it recommends that we inject 4 units of Botox Cosmetics for the frontalis. As beginners, we highly recommend you don't do this until you have a clear grasp of what muscle strength of a frontalis can tolerate a 4-unit injection. The most common complications associated with the frontalis muscle injection include brow ptosis and Spock brow. Brow ptosis can occur when the frontalis is treated without paralyzing the active brow depressor muscles, the procerus and the corrugators. Ideally, glabellar muscle should be injected simultaneously. Another cause of brow ptosis is when the frontalis muscle, which is hyperfunctional, support a normal ptotic lower eyelid. To avoid complete paralysis of the frontalis muscle, it is recommended to avoid injecting near the first horizontal line or at least 1 to 2 centimeters above the brow. Spock brow can occur when the lateral fibers of the frontalis muscle have not been paralyzed. The solution is to inject 1 to 2 units where you feel untreated lateral fibers of the frontalis muscle when you ask your patients to lift their eyebrows. It should be noted that some patients may actually prefer the smock brow look. Always palpate the frontalis muscle before injecting to understand its size and shape. This will help in determining the amount of botulinum toxin needed and the best injection site. Always avoid injecting near the lowest horizontal wrinkle line or at least 1 to 3 centimeters above the brow to prevent brow ptosis. When injecting the frontalis muscle, consider also treating the glabellar muscle to prevent brow ptosis. Be aware of the possibility of a smock brow and know how to correct it if it occurs. The orbicularis oculi is a single circumferential muscle group that functions like a sphincter or a purse string. The muscle originates from the medial palpebral ligament and inserts into the lateral palpebral raphe, corrugator, frontalis, and depressor supercilii. Its primary action involves pulling the skin of the forehead, temple, cheek towards the medial angle of the orbit, resulting in the closure of the eyelids. The landmark for the injection is 1 centimeter outside of the bony rim or 2 centimeters outside of the lateral canthus. Placing the non-injecting index finger into the bony rim can help identify this landmark. The injection site should not be below the zygomatic arch to avoid diffusion into the zygomatic muscles, which can affect the smile. The injection technique for the orbicularis oculi involves subcutaneous injection, typically 1 to 2 centimeters apart in a slightly curving arch. Each injection typically contains 3 units of botulinum toxin. Men may require additional 1 unit per injection site due to their typically thicker skin and stronger muscle mass. Please note, in the Botox Cosmetic package insert, it recommends using 4 units of Botox Cosmetics per injection site. The most common complication includes asymmetrical smile or diplopia due to migration of the toxin. To avoid this, it is crucial to inject 1 centimeter outside of the bony orbital rim. Excessive wrinkles underneath the lower lid may also become accentuated if the medial portions of the orbicularis oculi are left unopposed. This may require injection into the medial lower parts of the orbicularis oculi or the nasalis muscle. This is Dr. J. Park with Cosmetic Medical Training. Thank you very much, and contact us if you have any questions or concerns or need any additional help. Thank you.